The mic? It's working, okay. I'd like to thank Dr. Musa Akbar, Dr. Abdallah Shahab, and Dr. Fawaz Muteri, Dr. Khalid Bintani for this elegant meeting and sharing with you this case of calcific multivessel disease, which is the case. I've had two cases from the daily practice. It's not with the conferences and all this preparation. Our first case is a male, 68. He's hypertensive smoker and dyslipidemic. He presented with angina crescendo during the last 3 weeks. With a previous PCI has been done to the PD 8 years before his presentation to 2015. He has lateral hypokinesia with ejection fraction 60. ECG showed ST depression in the anterior as well as the inferior leads. The lab test was within normal, except that the LDL was 67 on atorvastatin 80. And this is, I don't have the whole angiogram, but this is the first picture showing diffuse calcific, very tight lesion in the LAD. The LAD is short, it's terminating before the apex. And sorry, this is the obtuse marginal, highly calcific. You can appreciate that the calcium here also affects the distal left main, starting from the left main. And this is the right coronary with a quite simple lesion. So the patient has been referred to surgery. And because of this calcification, and the patient came to me, then the strategy, of course, CABG is okay, his multivessel, left main included, but can we do anything with the PCI, especially the syntax score was near 31, imaging is a must, this is the strategy, and if PCI, which vessel would you start with? So this, I'd like this algorithm, first you start with the imaging, OCT or IVUS, and if severe calcification lesion on imaging, then if it is superficial, you have either the choices of balloon based with the cutting balloon or scoring balloon or high pressure balloon. Atherectomy also can be done. Of course, you can use also the IVL. If there is calcified nodule, then the IVL plus or minus atherectomy is okay. Deep calcium, the same IVL plus atherectomy. If the balloon catheter could not cross, then you can do exchange with atherectomy wire. If this is possible, go with atherectomy and then imaging and go to the left. If not, they go for laser. So I started here with the LCX lesion. It's more simple, and I've had the strategy to go with the rotablation. Usually, as the first case I shared in, it was 1995, the rotablator while I was in France. There was no IVUS, no OST. The second and third cases which I've done with Dr. Sobhi, it was 1998 with a proctor coming to us to Alexandria, and then in 2005 till 2012, I did all the cases with IVUS. But nowadays, it changed a little bit. This is the rota, this is 1.5. Yeah, it crossed a little bit with the high speed, then lower speed to ensure good ablation. And then after that, I took the balloon, and it was okay with a 1-to-1 balloon. Then what's next? Go and stand the LCX or change to the LED, get the wire off, and go to the LED. The LED is more complex. And with the same rotawire here, I use the microcatheter to exchange. Sometimes I'm using the parallel wire technique, but this is the rotawire. And this, I have difficulty using the same rotawire, which is 1.5. Some difficulties, of course, with the low speed, okay. I couldn't cross here. Still, I cannot cross. It's very tight lesion and heavily calcific. It's okay, several trials. Here is either you can have the mother and child, you can go for the slower, or you can have a high speed, or so what's the next step? The higher speed here. I'm afraid, but the rota to change to 1.25, I was afraid to get stuck. So I had the higher speed, keep persistent, and finally it's okay. Afterwards, you should have a good strategy because you're competing with the surgery, then measuring the length, going and stenting the LCX in a T way because the OS-LCX is not so involved, so no need for decay crush here. And actually, there to going to the left main, it's 2 stents to the left main, and after kissing, and this is the pot with the 4 balloon. It's okay. And after that, of course, this is the diagnostic catheter. It's so simple. Go and have direct stenting. It appears fresh. No need for anything. And this was the final result. The second case also has been a male, aged 78 years old, hypertension with angina class 3. He presented with angina class 3, but he has severe COPD. ECG showed ST in the anterolateral lead, echo preserved, and the GFR is normal because it's important with his age. The patient has been referred to surgery also, but he came to me because maybe there is a solution, and his high calcification of the LAD, the left main is not so involved here. The LAD is heavily calcified, and the right coronary also showing heavy calcium. And this, we have the strategy to go with the rota for the 3 vessels in the same setting. And this is the bear, 1.5, taking it several times, it crossed. After that, take the 1-to-1 balloon instead of IVUS, and it's okay. There is no dog bone, there is well inflated balloon, and this is the stent, long stent here with an excellent result, and then the post-dilatation. Make sure to have good post-dilatation. The CX is much more complex here. So the bear also, I took the 1.5. The 1.5 did cross after speeding high up, the same concept, 1-to-1 balloon, and then a long stent, and with an excellent result. The left main here is not so tight, so we deferred it if the patient tested. This is measuring also heavily calcified. They are saying the same bear, taking the same concept in the one session with a rotablation, and then the same concept, taking the balloon, and this is the final result. So the keynotes from these, that calcified lesions are still one of the most referring decision making the doctors refer the patient to CABG surgery. We all know that continuous technological developments in the field of interventional cardiology are mainly directed towards calcified lesion and CTO lesions, which is good because we still need of more invention in this field. Still, rotational atherectomy is the main and the most practical way in most calcified lesions in daily practice to achieve success as alternative to CABG. Thank you.